Hi, good evening, everyone, and welcome to NCAP's Sunday CE program. We're going to be talking about House Bill 67 this evening, and I am fortunate to be your speaker this evening, so I want to thank you for tuning in. It's a beautiful weekend, so thanks very much for tuning in. And I would say that tonight's program is accredited for 1 hour of continuing education. It's accredited as ACPE. Continuing education. I also want to let you know, many of you that have been regulars of ours that have been tuning in to attend our Sunday CE programs. Our host has been, for about a year and a half now, has been Jennifer Player. Jennifer was our executive fellow with the NCAP, and at the end of June, she finished up her 2-year fellowship with us. So Jennifer has now moved on from NCAP, and she has actually been hired by the state health plan. And so we're super excited for her future and what that holds, and the ability to take a lot of what she's been able to learn here at NCAP, and also in conjunction with all of our members. So as Jennifer has moved on, we actually have a new executive fellow who will be hosting many of our Sunday CE programs. And so in saying farewell to Jennifer, we're welcoming now Ty Chapman. And Ty's got his camera on. Ty is attended undergrad at Ohio State University. He's a native of Ohio, and he came down to North Carolina to earn his PharmD from UNC Eshelman School of Pharmacy. And he graduated this past May. And we feel very fortunate to be able to bring on Ty as our executive fellow. He is completing right now. He's just started a 2-year executive fellowship with NCAP in association leadership and management. And so I'm super stoked to have Ty join our team. You'll be seeing a lot of him in the future. And Ty, would you like to say a few words to the folks that are hanging out with us this evening for this webinar?
Definitely. Hey, everyone. It's a pleasure to be here tonight. I look forward to getting to know you all better throughout these next few years. And I also look forward to helping host and run these Sunday CEs.
All right. Let me share my screen for slides, and we'll get going. Ty, are you guys seeing the title slide at this point?
Yes.
All right, good. Everyone, I would say if you have questions, please, I'm going to hold and take questions at the end, but I know you may have questions that pop up along the way. So please type them into the chat. Ty's going to be hosting at the back end of this meeting. And any questions that you have, we're going to try to answer as many of those as possible as we get to the end of the session. So I'm going to move us through the first few slides pretty quickly, but this session is all about House Bill 67, and I'm trying to put kind of a tilt on it with regards to what's in it, but what does it really mean with regards to implications and opportunities for pharmacy practice. So let's see. Disclosure, no financial relationships to disclose to you regarding the content with this particular session. Also, this is not really for you this evening, but if you look at this slide deck later, we get closer to October 1 and the effective date for the enactment of House Bill 67. I wanted people to understand that what I am talking about tonight, and a lot of what I'll be sharing with you, is still technically in draft mode. We're very close, but so I feel pretty comfortable sharing a lot of what I'm sharing this evening, but I will say that there's possibility that there could be changes. So if you're looking at this after October 1st, you want to make sure that you are pulling down the most current available information, and that may not be this slide deck because we're wanting to give you a sneak peek. We're wanting to kind of share with you a little bit about how to prepare and what kinds of things to think about with regards to House Bill 67. All right, so for objectives, again, key provisions in the bill. We're going to share those. Also, what's been going on? Like since the passing of the law, what are the steps that are being taken towards implementation? Third is how to prepare for like being able to take advantage of these new opportunities. And then third, I want to try to illustrate some opportunities by mentioning sort of some of the applications of the different provisions, uh, paint some scenarios, and get your wheels turning and get you thinking about how you might be able to take some of these new authorities that are in this amazing piece of legislation and put it into action for your practice and for your community. So let's get started with the legislation. The main reason for this slide is so that you have a place where if you're looking at this content, you could easily click on the hyperlinks and take you right to the bill, which is number one at the top right. The passage of House Bill 67, yes, the name does not say pharmacy. It is a workforce reform bill. So healthcare workforce reform bill. It was sponsored by Representatives Reeder, Campbell, Potts, and Lambeth over in the House.
Hey, Penny,
And
real quick. Sorry to
yes,
interrupt. We had a request. Can you please click the swap display so they can see like the big screen of your slides? Because right now it's in presenter mode.
sorry, I thought you guys were seeing that. My bad, gang. Sorry. That's the two screen effect, right? So sorry. Yeah, I guess you can see this a whole heck of a lot better. Um, so with regards to this bill, it was a House bill that was used as a vehicle to put our pharmacy provisions into that bill. It's a huge healthcare bill. And I wanted you to be aware that our champions, though, were actually, yes, we had members of the House who were very supportive of what we were doing, but we have to give a lot of kudos to Senators Saari, Heiss, Bergen, and Galey, who ran the Senate versions of our bills that were able to keep all of these provisions alive to later be able to put them into this particular House bill for a larger healthcare bill. So House Bill 67 did pass in both chambers, and that bill is hyperlinked for you. And then over to the left, bottom left, is the law. So when a bill is signed into law, it becomes state law. Usually the first numbers refer to the year. So this is state law 2025-37. And I have hyperlinked the exact law, the law itself. So it'll take you right to that PDF. And that was signed on July 1st by Governor Stein. There are four key pharmacy-related provisions in this bill. They are found in Parts 5 and Part 7, and I provided you with the exact page numbers because it's a huge bill. Again, in trying to find the information, I wanted you to be able to know exactly where to go in the bill if you so choose to go look at it. And then the effective date for this piece of legislation is October 1st of this year. So what are those four pharmacy provisions? They are they basically amend or have additions to two different chapters in the North Carolina General Statutes. There is Chapter 90, which is all about scope. That's where the Pharmacy Practice Act can be found. And there's Chapter 58, which is all about insurance. Section 5.1B of the bill actually amends the Pharmacy Practice Act and has amendments to subsection B to add in the word administer. That's where you find what I refer to as like the traditional part of the Pharmacy Practice Act, where it says pharmacists, can dispense and monitor drugs, and there's a whole line of like verbs of things that we can do. But administer has been missing from our Pharmacy Practice Act. Just to have that, embedded into all of the different things related to medications that pharmacists should have the authority to do. So we've been trying for a long time to get administer added, and that was added to that subsection B of the Pharmacy Practice Act. Subsection E adds test and treat for influenza. And Section 7.1 of the bill amends multiple subsections of the Pharmacy Practice Act that pertain to collaborative practice. And I didn't want to, it would muddy up the slide tremendously if I were to try to get in all of those different subsections of the Pharmacy Practice Act where there are all these different revisions. But let me just say that the changes to collaborative practice are huge. It's what I refer to as a complete modernization of our collaborative practice statutes. And then the second part has to do with insurance. And this is where Section 5.2 of the bill adds in a new section, and that is General Statute 58-3-241 to the insurance statutes or codes. It does two things, actually, in scope and in professional liability. Pharmacists have been referred to as healthcare providers for many years. But over on the insurance side, pharmacists are not included among healthcare providers. So it does two things. One, it clearly delineates or designates pharmacists as healthcare providers among the insurance statutes. And two, it has language that requires health benefit plans to pay for pharmacist provided healthcare services. So let's talk about each one of these provisions, starting with administer medications. I mentioned we've been trying for a long time to get that one word, administer, added in alongside all the other actions that pharmacists are entrusted with in regards to the provision of medications to patients. During the pandemic, we tried again to run it, but we ran into opposition. However, because of the nuances surrounding patients not getting care during the pandemic, Representative Sasser was able to get long-acting injectable administration put in to our general statutes and added to the Pharmacy Practice Act. But the way that that was able to be done was utilizing the language pursuant to a prescription. Because of that exact language, pursuant to a prescription, it has done a couple of things. One, it has actually added this new authority for pharmacists to be able to administer a long-acting injectable. However, in some cases, because it's pursuant to the prescription, there are patients that need a pharmacist to inject, but because that medication is not being dispensed by the pharmacy that the pharmacist works for, there have been some barriers to care. And so we're wanting this new ability for the word administer into the General Pharmacy Practice Act to be able to help kind of overcome this barrier. And I'll speak a little bit more about that in a minute. So there are some scenarios. There are patients whose PBM mandates a specialty injectable to be shipped to the patient or shipped to a clinic, many times shipped directly to the patient via mail order by the PBM's preferred pharmacy. There are patients that live in group homes or live in independent living communities. Obviously, these are more vulnerable populations, and those two scenarios do not have like regularly staffed nursing staff, right, to be able to administer meds. And then there's the ability, we have this thought about the ability for pharmacists to give medications during a code. Like, are pharmacists allowed to do that in the situation of a code or not, right? And so we've fallen back on being more conservative because administer has not been in our Pharmacy Practice Act. And so by putting administer in, we're hoping to break down some of these barriers that have been out there. And but what's important to know, and this is a conversation that I've had with Jay Campbell over at the Board of Pharmacy, is that the passing of House Bill 67 does not necessarily repeal earlier legislation. However, there's a process that we have to go through, and that is looking at the legislation that was passed, thinking about rulemaking, thinking about, what are the implications in practice, and there has to be a closer look at what does this edition of administer up in the top part of the Pharmacy Practice Act. What does that do? And how can we sort of look to opening up medication administration for pharmacists? And so the answer to breaking down all these barriers is not yet known. And I want to be very clear about that today as I'm presenting, because I know some of you may have encountered some of these barriers. So what is NCAP doing? So I can speak for NCAP. So we are advocating for open administration of medications as long as the pharmacist feels comfortable administering the product. So for an example, when a drug is shipped to a patient, are you comfortable with how it has been received and stored? Are you, feeling that, oh, you're pretty certain this is not, that it's not been adulterated, right? And the way I think about this is we're wanting pharmacists to have this authority to administer no differently than like a home health nurse or an individual that would have to take a medication that's been dispensed by a pharmacy, and they're the individual that's coming in and having to help that patient with the medication administration. So we will, NCAP, again, speaking, what is NCAP doing? We're advocating for open administration. We're running legislation to try to achieve open administration. We are willing to assist the Board of Pharmacy as they review this and as they look. And if they would like our input, we certainly are there. We work very closely with them. And if requested, we'll provide that input. If needed, NCAP will turn right back around and gear up to run a technical correction. And the reason for that is the intent behind why that language, particularly around long-acting injectable administration, had pursuant to a prescription. It was because the medical society and family medicine docs, etc., were fine with pharmacists administering a long-acting injectable. They just did not want them prescribing it. And so somehow in the passing of that language, the verbiage of pursuant to a prescription, what it ended up doing is it tied the product and the administration to a staff under the umbrella of a single pharmacy. And that's where some barriers have popped up in care that we need to try to work through. And that's what we're trying to do. In the meantime, I'll be talking later about collaborative practice. We have wide open flexibilities in collaborative practice, and it's gotten better with the passing of House Bill 67 and the ability for you to think about in the situation of a group home or an independent living. Now with these wide open flexibilities of collaborative practice, there's the possibility of utilizing a collaborative practice agreement to be able to break through some of these barriers for getting administration of long-acting injectables to patients where the direct provision of administering drugs may not quite be there yet. We could always go back to utilizing collaborative practice to be able to do that. And I'll speak a little bit later about the collaborative practice changes. So test and treat for flu was the second provision that I mentioned. What's been happening? Let's start with July 1, the signing of the bill. So the signing of the bill is July 1. July 1 to 15, NCAP is working on drafting a flu protocol that aligns with the legislation. July 15 to August 1, multiple meetings, reviews, revisions, in collaboration with DHHS, and also the Board of Pharmacy is looped in. Now what's happening is DHHS, keep in mind there's been drafting, revisions, etc. So the first draft that we had back in early July is not the draft we have today, but now we're very close. And so DHHS is now circulating that draft to our medicine colleagues and getting their input. And then by October 1, what we envision is Dr. Greenblatt, who is the state medical director, will sign the protocol as a standing order. The difference between a standing order and a statewide protocol. Both use a protocol, first of all. But the difference between the verbiage, standing order, and statewide protocol is a standing order, the prescriber is the person who signs it, and that is, in our case, for our state, the state medical director. So it would be Dr. Greenblatt. A statewide protocol, the prescriber of record is the pharmacist that provides the drug. So why are we not going directly to a statewide protocol first? The reason for that is it is easier if we can get a standing order in place for the Board of Pharmacy and the Board of Medicine to come to agreement. If they could point to, we've had a standing order in place for X amount of time and we've had no issues, let's both adopt the protocol that has already been working well. That is a strategy for trying to keep there from being delays to implementation. If we were to try to come out of the gate with a statewide protocol, it is very likely that we would not be able to stand this up by this October, and we would be delayed. And patients need our help, particularly with test and treat for flu. All you got to do is look at last year's flu season and look at the morbidity and mortality around that. So some things I want to share with you about test and treat for flu. There will actually be two protocols. One is testing and treating patients that have flu. The other is a chemoprophylactic protocol for high-risk patients that have had close contact exposure. And I'll give you a little bit more detail on that on a later slide. The other thing that I want to share with you is North Carolina's treatment protocol will be more open than any other states thus far. And why is that? The main reason for that is how we have gone about putting together our protocol. We put the protocol together, and where did we start? We started with other states' protocols. We pulled all of those together, we aligned with our legislation, and we drafted. Then we started in those conversations with DHHS, and questions were asked by our medical and our public health folks in DHHS. Why are there all these individuals being excluded? They're excluded in other states. Why is that? These are the very people who need to be treated, that need pharmacists getting to them and treating them. They're the people that are most vulnerable, most likely to end up in the hospital, to end up dying from the flu. We need pharmacists treating them. And so our DHHS has been very open in working with us in opening up our protocol and moving what are in many other states, people that would be excluded. And you would have to say, I'm sorry, you have the flu, but you need to go to your doctor because you're at high risk because of blank. You need to see your physician or you need to go to urgent care. In our case, once the protocol is signed, if the version that I share with you in just a minute is the version that is signed, you will see that pharmacists will have free rein to be able to get those individuals treated as quickly as possible. Pharmacists who perform assessment and testing for flu under the statewide standing order or statewide protocol will need to complete an ACPE accredited CLIA Wave point of care education and training program. You'll need to remain up to date with current CDC recommendations regarding treatment of influenza. You will need to ensure that individuals that work under your supervision that are involved in specimen collection, that they have received appropriate training and that you've documented their training, and that their training must include appropriate infection control practices. And then outside of the normal flu season, which is typically October 1 to April 30th, you need to use your clinical judgment in assessing patients pursuant to the protocol and implementing treatment. We know that there are outliers. People get the flu in September, maybe as late as May. So it is it is possible it'll be outside of the normal flu season. You have to use your clinical judgment as to how that best fits into the service that you're providing within your practice. So what is our protocol looking like thus far? So again, note the watermark. It's faint, but it does say draft. However, we're very close and we think we're going to get some feedback, but we do believe that we'll be able to move forward with most of this. So again, keep in mind, I'm giving you sneak peek, but there could be changes. We're talking individuals 5 years and older. Yes, you have to have parent or guardian consent for a minor. Complaints of any sign or symptom of flu, and those are listed. Testing is, you deem that clinically appropriate based off of your professional judgment. And then any individual in these high risk categories that are listed here in the red box, you are able, they want you to prioritize them for testing and treatment, is what this is saying. So again, I'm very excited for our state and what this is going to look like moving forward and the impact that it is going to have, the ability for you to make a huge difference in your community. Test and treat in the eligibility. So that was the inclusion. So what does the exclusion look like? Well, obviously the reverse. So the symptoms have to be within 48 hours. So if it's longer than 48 hours, they're outside of the window. So no treatment, no time. You can test them to tell them what they have and do some symptom management and so forth, but you're not going to be able to prescribe antivirals for it. Obviously, individuals under the age of 5, end-stage renal disease on either form of dialysis, those are excluded. Obviously, if they've been taking antiviral for flu within the past 4 weeks, those individuals would be excluded. And what this bottom one is kind of marred out by the line, it says clinically unstable based on clinical judgment of the pharmacist and any of the following. And that's what I wanted to emphasize is the following. Altered mental status, a BP that's listed there. Children, it's based off of systolic calculation there for you. Respiratory rate is listed. So it's based off of their blood pressure, the respiratory rate, their O2 sat, and their temperature. And so if they hit any of these particular thresholds, then those are individuals that are considered clinically unstable. You will not be able to treat them, but you're going to be requested to advise them on what they should do, that they need to seek immediate attention and care. And so there is a note on here that says meeting an exclusion criteria. So the individuals at the top that are excluded, you can test them to tell them that they have flu. You can test them. The fact that they're excluded has to do with the ability for you to prescribe an antiviral. So testing them and advising them and getting them to understand what care they need, that's equally important. And so that's part of the protocol as well. The other reason I have this box highlighted is this should get your wheels turning to thinking about what equipment you may need to have in place for the service, including ability to weigh individuals that are under the age of 18, because in many cases with children, the antiviral dosage is weight-based. And then I want you to be aware that NCAP is working on templates to help you in practice, questionnaires, documentation forms, a clinical guidance document to kind of accompany the protocol itself. We're putting together educational programming. And in fact, we're going to have our Sunday CE program in October is going to be a program about this protocol and about influenza in general. We'll have Dr. Greenblatt as one of our speakers for that program in October. And then we are partnering to bring a national ACPE accredited point of care training program with multiple dates for you to be able to register, to be able to get in to do that point of care testing. And so NCAP is putting in place everything to help you stand up and be ready to provide this service. So there are many other components to the protocol. I've listed them with bullet points here. They're no different than any of our other protocols, with the exception of, because it involves a point of care test, there's a specific section with what to do when the test is positive versus what to do when the test is negative. But the other components for the protocol are pretty straightforward when compared to our other protocol sections that we have for things like birth control, um, tobacco cessation, HIV, PEP, etc. The separate protocol for chemoprophylaxis for patients with close exposure. Again, those are individuals 5 years of age or older that have had close contact exposure to flu within the past 48 hours. And in this case, they have to be one of a high risk group that will be listed in the chemoprophylactic protocol. So, two separate protocols. But you will be able to help people like a spouse situation, right? Where one household member has the flu and the other one's been obviously exposed to them. And then maybe another example would be at work, where an individual sitting next to someone at work, their colleague had to go home sick. They called back, said they have the flu, and the person sitting right next to them has had close contact. So again, there's a mention of that CE in October. It will have Cheryl Viracola, our Director of Practice Advancement, who's been the main person on NCAP staff that has been working on the flu protocol in conjunction with Dr. Greenblatt. And the two of them will be doing that program in October. Okay, slides don't want to advance anymore. Let's see. I think it was a delay. All right. Test and treat for flu. What can you be doing now? So here are some of the things that I thought would be helpful. If your wheels aren't already turning, thought I would put this in. First is information. Just continuing to stay abreast of what is developing. You can stay in the know with NCAP and the Board of Pharmacy. We both are going to be putting out information about the flu protocol as we get closer to the enactment date. More information will be coming, and keep in mind that everything tonight, again, I'm reminding you in case you tuned in late, technically what I'm presenting tonight are drafts. The other thing to think about is in the middle box, professional development. So have you in the past, have you taken a CLIA Wave point of care training program? Maybe you did one under one of our national organizations. Maybe you did the one that NCAP offered back in 2019. If you have done a point of care training program, one of the things you could do is find proof that you did that training. It's probably in your CPE monitor, going back in time and looking for that program to show that you have done a CLIA waived point of care training that was ACPE accredited. If you've not done a point of care training program, then consider signing up for one of the training dates that we will be putting out, or you can go out and find your own CLIA Wave point of care training program and sign up for it under another umbrella. Policies and, the middle box goes all the way down. The other two are on the side. So another thing about professional development is if you and your staff need continuing education more broadly about influenza, is thinking about or the management of influenza is thinking about identifying how will you obtain that information. We'll have some things available under NCAP, but you may decide that you want to look for additional information out there. Maybe it's a readable kind of self-study thing, or maybe it's actually a CE program on influenza. So we will have more stuff coming, but that's something for you to be thinking about. What do you and what do your staff need? And then keep in mind that other professional development piece about if your staff are going to help you with specimen collection, they have to be trained. Will you train them? Are you allowed to train them? And the answer to that is Yes. However, you might want them to take the point of care training themselves. So really, that's going to be your call. The other option too would be what else do you need to put in place education-wise about infection control and good practices around that. Policies, let's go to policies and documentation. So think about the policies that you will need to have in place for your practice and your staff. Processes that you might need, how you're going to document things, even like training, and how are you going to maintain those records, and just keeping that information. Where are you going to house it? What are you going to record? And some of that will be in the protocol itself. But in general, it's going to tell you that you need to document the training and need to retain the records for X amount of time. But you internally need to think about what does that mean for you and your staff, and what are the things that you need to think about with regards to keeping your information. Reliable test. So there's a lot of point of care stuff out there, but what point of care test? Think about what are reputable companies? What's the accuracy? So what's that sensitivity and specificity of the test that you might be using or choosing to use? And start thinking about which test are you going to put into your service? And then the service itself, what's the workflow going to look like? Who's going to do what? Where will the service be provided? What PPE or equipment will you need? And think about your cost and the need to calculate a cash-based service model for your practice. So those are all things that you could be working on in the interim as we're moving towards and through that process of enactment to get to what's needed to be able to move forward with implementation. Payment for pharmacist provided healthcare services was the next provision. That's the part that was amended in the insurance statutes in Chapter 58 of the general statutes. Historical, I'll just say we've been trying a long time. I mentioned that we've been listed as healthcare providers, but really we're oftentimes what I'll call discriminated against because it doesn't clearly illuminate in our insurance statutes that health plans have to pay us for anything that we do. The fix is, back in 2019, we began working on amendments to the insurance statute. We wanted to try to memorialize pharmacists as healthcare providers, and we wanted to try to move forward language that would lead to payment for pharmacists for anything that you can do that's within your scope of practice. Your scope of practice as a pharmacist versus your scope of practice as a CPP. Those are different. Your scope of practice as a CPP is addressed within your collaborative practice agreement, but payment should be based off of what you are allowed to do legally. And so what we wanted to do was to try to get that language into the insurance statute. So in 2025, we finally got the bill to pass. It's the same bill language that was run in 2023 that got cut out of the bill at the 11th and a half hour before a midnight vote. I will say that in 2023, the state health plan opposed our bill. In 2025, they did not. And we wrote the bill to have very agnostic language, meaning that it would apply to all health plans, including commercial, Medicaid, state health plan. However, does it apply to Medicaid and the state health plan? This is a huge question. So I want to say that health benefit plan wording was not our wording. Bill drafting used that wording with the reasoning of health insurance plan was not defined in North Carolina law, but health benefit plan was. Neither we nor the bill sponsors were aware of a piece of legislation that was passed in 1999 called the Applicability of Acts of the General Assembly to Health Benefit Plans. And the general statute number is there for you. And you can read that, but it basically says anything passed by the General Assembly that has health benefit plan in it does not apply to Medicaid or state health plan, state teachers plan, etc. However, What does that mean? That does not mean that Medicaid state health plan can't choose to participate, but they could lean into it and say we don't have to because we're not considered a health benefit plan. They could lean into that, but we are hoping for test and treat for flu that they're not going to lean into that. We're working on it, and I'll show you some steps that we're taking. But I will say that technically that they could lean on that earlier language. However, I'm going to point to 2021. We passed legislation around birth control and PEP. Medicaid was the first to go, yeah, we want to pay pharmacists for this. And they started stepping up to get in, pharmacist enrollment in place and to move towards payment. So what is the work that we're doing on payment? Think of it in three buckets: Medicaid, state health plan, commercial. Yes, Medicaid's initial stance in our first conversations on the pharmacy side has been, due to budget cuts and this earlier legislation, they're not going to pay for test and treat for flu. However, we have also had conversations with Dr. Greenblatt, and he is very supportive of wanting to see pharmacists paid for this because it would save Medicaid money. Senator Sari has weighed in on this, and with regards to the intent, and the legislation was not that Medicaid would be carved out, but that we would use it to help our vulnerable populations. And then the next meeting that we are trying to get in place is with Dr. Greenblatt and Deputy Secretary Ludlam, and also Medicaid's Chief Medical Officer, Dr. Janelle White. We are very hopeful, just based off of the fact that we know that we can save Medicaid money. And if we're leaning on budget cuts as a reason, this is all the more reason that we should get Medicaid paying for pharmacists to test and treat for flu as quickly as possible, because that population certainly goes to urgent care and the ED and hospitals for help when they are sick. And then state health plan, what are we doing? Tom Friedman's the executive administrator for the state health plan. He's been very open. He's been meeting with a number of pharmacists all over the state. It's a breath of fresh air, quite frankly, for the state health plan. Very open to pharmacists helping the state health plan get their beneficiaries healthier and saving the health plan money. I have another meeting this coming week with Tom Friedman. There are a number of meetings going on with him, but the purpose for my meeting this coming week is about House Bill 67 and this 1999 legislation. I want to get to the stance for the state health plan regarding this winter's flu season. And I would like to have Tom get a meeting set up with Aetna, because we need to get moving with Aetna to be able to stand up credentialing and networking. And the window of that is, it's not a completely open window. So the thought here is, in the beginning, we may need a cash model to stand this up, but we need to be moving towards getting that credentialing and that networking in place, so that when we come back around full circle in a year, this is ironed out completely and it is in place and we're ready to rock and roll. And then the commercial side, this is a long game. Every state that's gotten commercial payers so far, it is not a flip the switch and everybody's paying. We have to have meetings after meetings after meetings, getting people to the table to talk through credentialing and how do we do networking, etc. I will say we also need to have a meeting with the Department of Insurance to talk about House Bill 67 and the implications and the enforcement of it, because commercial is certainly not. They don't have that 1999 legislation to lean into. They are, without a doubt, they should be stepping up to pay for this. But we know it's not going to be an immediate game. It's going to be a long game moving towards making the changes that are needed to be able to get it going. Collaborative practice, huge change, guys. I cannot emphasize how important this is. Another way to think about our collaborative practice will now have so many earlier barriers broken down. It has tremendous flexibilities, the ability to expand collaborative practice in many different ways in all healthcare settings. And I'm going to speak to just really briefly 4 big buckets. So we have moved from having very restricted collaborative practice agreement language framed around drug, disease, patient, doctor, pharmacist specific language to having pharmacists being able to collaborate with medical providers for the purpose of providing pharmacotherapy, disease management, and population health care. Those are very, just think about that language being so much more open than drug, disease, patient, doctor, pharmacist specific, right? And so I've got some implication slides a little later, but I just want to mention that the language is much more flexible. Direct patient referral to a CPP will be allowed now. There are a lot of barriers that we've seen with collaborative practice where a patient wants, like a doctor wants to send a patient direct to a CPP, but for compliance, legal reasons, the patient's being made to see that CPP supervising physician first, even though that supervising physician isn't really necessary. The patient has their own doctor. Just so much crazy barrier stuff out there. So now it's written in such a way that, yes, CPPs could have patients refer to them directly. Site-specific multi-provider agreements. So I've chosen UNC. It could be any other health system, so I'm not picking on UNC. It's just an example. This means when we're talking about a health system, UNC Rex could have a single collaborative practice agreement with multiple providers, multiple CPPs on the same agreement for the provision of X. But it does not mean that UNC Health, meaning health system wide, like all of UNC Health having a single agreement with providers and CPPs all over the state on a single agreement. So it's site specific, in quote, site. Think of a community pharmacy as a site, right? So a community pharmacy could write up a collaborative practice agreement for X, circulate it to providers in their community, have providers signing on, as long as that community pharmacist CPPs, pharmacy CPPs, have a supervising physician on that agreement, they could have multiple providers signing on to that. And so the site is the community pharmacy. So you can have multiple providers, multiple CPPs that are part of that community pharmacy system being on that agreement. So that's giving you 2 different examples, health system, community. And then there's a pathway under the changes to allow for PAs and nurse practitioners to also collaborate. Whereas in the past, they were prohibited from participating. Now, some things to point out. I can get this to move so I can see. Sorry, guys. CPP qualifications did not change, like who can be a CPP. But I will say there's a subcommittee that's been put in place by the Board of Pharmacy that it's a team of people that are working on reviewing those qualifications that perhaps in time, those may or may not change. So they're pretty flexible, quite frankly, but it's a possibility they could change. But we're not looking to change those by October because if we go to trying to put these rules in place while also changing the qualifications, it's going to create a delay in implementation. And we don't want to do that. So what we want to do is try to stand this up and then take the work of the subcommittee and later come back and maybe look at the qualifications. But another thing to think about with regards to collaborative practice in this bill is the healthcare services, the way that they were defined as medical tasks, acts, or functions, such as initiating, changing, discontinuing drugs, or ordering tests and devices. So I'm reading this to you. To assist. Now it's to assist with drug therapy, disease, and population health management. The details, you got to have your details in your collaborative practice agreements. And this, you got to have a supervising physician. Each CPP has to have a supervising physician. Could it be the same person? Yes. Um, but once something that's new is that you can have a statement of authorization in your collaborative practice agreement that allows for therapeutic substitution within the same therapeutic class or for a biosimilar medication. That was previously also not allowed. One big thing is CPPs. CPPs will need to still be approved through the normal approval process, but collaborative practice agreements will no longer be reviewed by a joint committee and approved by the Board of Pharmacies or by that joint committee. It's a move toward professionals must be responsible for what it is that they're doing. There will be disciplinary action taken for complaints that uncover negligence or unprofessional conduct, or obviously, if patients are injured by something that you're doing, or if you're stepping outside of what's legally allowed or what's legally written into your agreement. But the approval of agreements is going to go away based off of draft guidance. Supervision number. The supervision number is now more open. So where we've had situations of where care has had to come to a screeching halt because the doc was working with an individual that technically they weren't a supervising physician for, now we're going to break through that barrier. And there's the ability for physicians to supervise as many individuals as they deem can be safely and effectively supervised. And then, I'm sorry, I think I just skirted through that. Where can CPP care be provided? So also kind of different is collaborative practice agreement. The supervising physician needs to identify the location. The location. That location can be fully, partially embedded in their practice, in a site. Keep in mind, a site could be a community pharmacy. And in the past, we've pretty much, mainly because of payment, have limited where care has been provided for the most part. When we look at totality of collaborative agreements, it's been delivered in physician offices. So I will say this is going to be way more open, and it's truly an exciting time for our state. Practice implications. The barriers in the past have been restrictive language statutorily, not because the Board of Pharmacy wanted to make things more restrictive. They have to abide by what's written into the statutes. And payment. And then the supervising part, like our supervising language was different than what you saw for nurse practitioners and PAs. You didn't have to first see a nurse practitioner supervising physician before you could see a nurse practitioner. And Ty's bringing on his camera, so I know we're running late here probably. This is the last slide before the questions slide. But what I want to share with you is you have endless options now with regard. If you can dream it, you can pretty much put it into a collaborative practice agreement now. Population health aspect of this is really going to blow the doors wide open for both health systems and also for community pharmacists. And I want to speak to rural areas specifically, but a lot of this could also apply in urban areas. But I want to talk from a rural standpoint because I think it's easier to grasp maybe how some of these new changes could really make a difference in what you are able to do because of the closeness of when you practice in a rural area, the vast majority of your patients' prescriptions are written by, a smaller number of physicians or nurse practitioners than what you see in an urban area. And so what I want you to think about is if you're in an area where you have a handful of docs that you see a lot of their patients, you now have wide open opportunities for framing out collaborative practice agreements that can do things that we normally traditionally think of. So like my cursor is highlighting specific chronic disease and management services. We normally think of collaborative practice for things like diabetes and hypertension and so forth. But think about that earlier example that I gave you about the group home LAI administration. If we do have to go back and run a technical correction kind of piece of legislation to repeal the pursuant to a prescription for LAI administration, is there something else that you could do? Yes, you could do a collaborative practice agreement with a provider to allow you to do LAI administration in that group home. You could utilize a collaborative practice agreement with a key group of docs to cut down on all that back and forth fax and phone communication for formulary management stuff. This person's insurance doesn't cover this drug, but it does cover this drug. And you got a delay in being able to get the drug to the patient because now you got to go back to the doc to get their approval to make that change. If you had a really good relationship with certain physicians or nurse practitioners under a supervising physician, that you could frame a collaborative practice agreement to be able to do therapeutic substitution within a therapeutic class or with biosimilars, you could write an agreement just around that. You could also build agreements to do things like test and treat for things other than flu. And you could do a collaborative practice agreement to build up services in your community that are needed. Maybe your community doesn't have enough treatment facilities for OUD, opioid use disorder. Maybe you want to start working with a local health director to expand HIV and other sexually transmitted infection services. The world is wide open for you to think about what makes sense for your community, for your practice. And I'll roll to the Q&A slide where I'm going to say that as NCAP staff, we are willing to help our members frame collaborative practice agreements. We've done that in the past to help some folks particularly in the community setting, think about how they could build a collaborative practice agreement for flu before we had test and treat for flu. And if you've never done a collaborative practice agreement in the past, you're going to have questions. And we'd be happy to speak with you and help you talk through like what it is that you're trying to do, what your needs are, and we could maybe help you think about how you might be able to build that out and frame it. And we're happy to do that for our members. We also want to say that we're going to be building more resources for collaborative practice now that our bill has passed. We're working on that. And then also building and bringing more medical billing resources to you. So those are coming as well. And I mentioned earlier the flu resources that we're building, and those will be available first before all the other stuff is ready because we're trying to stand up, test, and treat for flu before anything else. All right, so I am happy to take questions. I know we are probably over time by about a minute for the hour. Ty, do you want to do the closing information? And then what I'll do is hang on to answer questions just in case there are people that need to leave and they want to know about CE and what other sessions are coming up.
Sure thing. So some upcoming things to look out for. We're going to have a anti-infective conference coming up soon. So check the NCAP website. That'll be in Greensboro in October. And then also be on the lookout for our next CE in September. It's going to be on the 21st. And that's Paul Shelton on the topic of pharmacy at home, one future for long-term care. And then in October, we'll be on the topic of influenza and review of the standing order. And then the presenters for that one are going to be NCAP's Director of Practice Advancement, so Sherville Cola, and the State Medical Director, Dr. Larry Greenblatt. And that's kind of like the big picture for the next 3 months.
And then for CE.
Oh yeah, and then for CE credit, just make sure you get an email by tomorrow by the end of business day from Angie Broughton. And then if you don't have an email by tomorrow, then give us a call or reach out to the office on Tuesday, and we'll help you out with that.
Okay, so questions. If anyone has questions, I'm happy to try to answer those. I don't know if any were put into the chat. or
Yeah, we got a few up here, and Cheryl did a great job of answering some as they came in. The first one that I haven't seen the answer for yet was if the pharmacy charges the patient cash for test and treat, um, the patient should be able to submit the claim to their insurance for payment. Is that correct?
they should be able to submit it. But I honestly don't know how that, whether that's going to be received or, if it's going to be accepted by their insurance. But it's certainly worth a try. But let me share something with you about a cash model for test and treat. I'm going to use my own personal situation. So NCAP provides, we go out and shop for insurance. We have a Silver Blue Cross and Blue Shield plan that we provide to our staff. And when we look at copay, so if I get sick and I need to get I think, oh, I might have the flu, right? Well, getting my primary care doctor to see me, it's not going to happen within a 48-hour window. I'm at best they would offer a telehealth visit. Where telehealth you can't diagnose flu. So, the thought is I'd rather go to my pharmacist, my independent pharmacist, and have my pharmacist actually test and treat me if I had the flu than to go to urgent care. And I'm going to share with you, like, I know that there are many other people out there that are like this, but our copay for our health insurance to go to urgent care is $500 to walk through the door. Now, the reason that I'm saying that is to go to urgent care, depending on the insurance that you have, I know that you guys are offering test and treat services for, like, when you were doing COVID and you were doing test and treat for COVID, or when you're doing, I've heard from some that you test for both COVID and flu when you're doing that. But I know that you can build a cash model that's going to not only recoup your cost, but make you some profit. And you're still going to be able to offer a service, a timely service, an accessible service, and an affordable service compared to what it's going to cost many people where their only other option is to go to urgent care. And so I just share that we can't talk we can't talk money, like let's work out a cash model on continuing education, because that's a violation of antitrust. But I'm sharing that example because I know that you're going to have many other people in your community where they're going to love to be able to come to you and gladly pay whatever your cash price is to be able to get your care in an accessible manner versus having to go to urgent care and sit in a waiting room for, huge amounts of time and have to pay huge copays to do so.
And we had another question. So, under House Bill 67, do CPP still need a referral for an individual patient for a specific diagnosis?
Say that again.
Under House Bill 67, do CPP still need a referral for an individual patient for a specific diagnosis?
With CPPs, the my understanding, and I know we've got a lot of CPPs on the call tonight, and some have also been involved in some of the background work that's going on. I can only speak to barriers that I am aware of. So I'm not sure exactly what you have to be able to take a referral, but I know that there are collaborative practice agreements that can be written around, and under these new changes, there will be collaborative practice agreements that can be written around um, population health. And in that case, we're talking about, if not a disease that someone has, like diabetes or hypertension, or you name it, they have a condition, right? So there's gonna be the ability, we believe, if the rulemaking gets through, to allow, if a physician is willing to partner with you, to do an open population health agreement around patients coming in with certain symptoms that you then test for and you find that they have X, if your agreement is written around X, you should be able to provide care. Now, they're not being referred to you with a diagnosis already. They're coming with certain conditions, and you're working them up through an assessment under the guidance of your agreement. So, I'm not sure about the diagnosis part. I think in the past, the barrier has been, even with a diagnosis, CPPs have not been allowed to see patients until they've seen the supervising physician before. And that certainly is getting taken care of. Like, that will no longer be the case.
And that was actually part of a two-part question. The second part, you may have already answered this, but I was just going to read it for completion. Can a doctor refer all their patients that meet a criteria? For example, if they have an A1C greater than 9.
Yes, they could. They can do that now, actually, under a collaborative practice agreement. But um, I think the thing we need to think about is there have been a lot of things that have not been allowed, and there's going to be a lot of growth and expand, ability to expand what we're able to do under collaborative practice in every healthcare setting. But I think we're going to finally, and this is what the legislators really wanted to see happen. They know there's great work happening in our health systems, and even though the bill would help with some barriers there, they specifically want to see collaborative practice expanding in the community setting. And so we've tried to do this in a way that is as open and flexible as possible.
And this next question is talking about from federal law changes, substance use disorder treatments like buprenorphine specifically left out pharmacists when talking about like different providers who can kind of like help with that condition, like doing some of the medical services. So the question is, will House Bill 67 kind of open this up more for pharmacists to do services like that?
Okay, so that is a lot in that question. Um, and I'm not so certain that all of that was accurate. Cheryl is my buprenorphine expert. Cheryl, are you still on the webinar? Could we unmute you, maybe? Ty, can we unmute her?
Yeah, let's see.
Let me stop sharing. Is she still on? She may not still be on.
I'm on.
Oh, good. There's your mic. Wonderful. Hey, Cheryl, did you catch that question? Because I wasn't sure that all that was accurate at the top.
Yeah,
Because
I'm having a hard time understanding it. If you're talking about treatment and buprenorphine federal law changes, so with with the removal of the DEAX waiver, which happened several years ago, what that did for pharmacists in North Carolina specifically, it did open up the door for pharmacists to be able to obtain a DEA number and to provide buprenorphine. So if there was a collaborative practice agreement in place, then absolutely, pharmacists in North Carolina, if you have a DEA under a collaborative practice, you can prescribe the buprenorphine. Now, I'm not sure if that's the question or not. It opened up the door for PAs, NPs, MDs, and DOs, obviously, and primary care. But, for North Carolina specifically, it opened the door to pharmacists as well. That's not true in all states, but it is here. So yes, and we have pharmacists that are working under a collaborative practice agreement with a DEA and are providing buprenorphine under their licensure.
Yeah, that was what I was going to say, is that we've actually had some pilots where we've had pharmacists under a collaborative practice agreement doing exactly that.
Yeah, and I dropped the question into the chat to see if there's anything that can be gleaned from the exact wording of the question, just in case. But thank you for piecing together a response. We got another question that says, this goes back to the pursuant to prescription language. The way I've interpreted is that the patient has a prescription for the med, even if I can't fill it, especially pharmacy required, it exists, and so I should be able to administer the long-acting injectable. Is that wrong?
Yes. It's not, I'll say this, it is not what was really intended in the passing of the legislation to allow pharmacists to administer long-acting injectables, but I really don't know how that pursuant to a prescription language came about, but the Board of Pharmacy, so that's a legal term, pursuant to X, whatever X is. The way that I'm kind of like you, right? From just I'm just going to say, like, from a practice standpoint, yes, a patient has a prescription for long-acting injectable, and yes, I'm a pharmacist. I've done my long-acting injectable training. I should be able to administer the long-acting injectable. And now, particularly since we have administer in our regular the regular lines of our Pharmacy Practice Act, I don't know what else to call that, maybe historical lines of our Pharmacy Practice Act, even more so, we should be able to do that, right? But my understanding about this is it is a legal term that ties the administration to the prescription. And the way it's been explained to me is if you are not the pharmacy that is dispensing that prescription, you don't have the legal record that authorizes you to administer it. And that's kind of the best way I know to explain it. And this has become a barrier to care. And we were trying to fix that barrier to care. But, and we may still get it fixed, but I'm just telling you that the way that legal pursuant to a prescription for a long-acting injection, because it says a pharmacist may administer a long-acting injectable pursuant to a prescription for a long-acting injectable. And it's that pursuant to X that ties the two together. So if CVS specialty pharmacy mails a long-acting injectable to a patient in the community and they bring it into you and ask if you can administer it legally, right now, legally, you cannot legally administer that. And that's where we say, well, patients otherwise aren't going to get the drug that they need. You know, what do we do, right? We're between a rock and a hard place. And so I'm sharing that with you because this has come up in recent discussions and I'm trying to work. I've offered scenarios of where we've got barriers that we need to try to fix those barriers. And it may be that, this addition of the word administer gets interpreted differently. But right now, I'm being told it does not necessarily repeal earlier legislation. So the Board of Pharmacy has been working on the collaborative practice rules and guidance because those are major changes that have to get stood up by October. DHHS is working with NCAP to stand up the test and treat for flu as quickly as possible. And although the administered drugs also is in House Bill 67 goes into effect October 1st, the reality is we have more time to try to work through that and figure it out. And so I don't even know that the Board of Pharmacy has had time to really really work through what does this addition of the word administer mean? What does it do? So, but I'm just speaking tonight to answer that question based off of the law right now for long-acting injectables.
Thank you. And we had a question about kind of like the level of billing when it comes to these CPP medical services. So they asked, would the new billing provisions allow CPPs to bill at the same level as other providers for state or commercial insurers? For example, my provider seeing a patient can bill level 3 through 4 for office visits, but pharmacists can only bill level 1. And we had a partial response to that question, but I just wanted to see if you or Cheryl had any other expertise to share with the group.
So in the past, when I have asked, and this predates Angela Smith and John Mata. This is going back to John Stansel when he was the pharmacy director for Medicaid. Back when the payment for CPPs came about for Medicaid, at that time, I was told that a CPP can bill for the level of service that they provide in any healthcare setting. So it could be a doctor's office, it could be a long-term care setting, it could be technically, I guess, the community, but we just don't see a lot of CPPs under agreements and like purely working out of a pharmacy. We have some, but it's just not a large number. But for Medicaid, we were told that they can bill for the level of service that they provide. But the problem comes when a lot of times when it comes to billing, and I don't know who's asking this question or why it's being asked, but a lot of times, because Medicaid falls, it's under CMS, right? So when we talk about seeing patients in a setting, and sometimes you've got Medicare patients and sometimes you've got Medicaid patients, what we have often heard is that CMS will only allow for billing at a certain level, and therefore, a lot of times the compliance teams within a health system will only allow a CPP to bill at a certain level in order for, I think, for a couple of reasons, consistency, but also not to end up in a situation of where under CMS, a Medicare patient has inadvertently been billed at too high of a level above what, not that you were not delivering service at that level, but that Medicare is not going to pay for the service when a pharmacist provides it at that level. So that's my understanding, but I honestly, like I said, there are a lot of other folks out there that are more involved that have been CPPs for a long time and that have had to deal with billing in their healthcare setting. I don't know if that helped or just muddied the water more.
Thank you. Another question came in. A comment, they said, I'm glad to hear that the state health plan is supportive of the work we do as pharmacists. And then the question, do you also plan on discussing the issue of copays for Humana Medicare Advantage PPO state employee retirees during your meeting? They are $20 a month for CCM and $20 a month for RPM. This costs a substantial barrier that prevents patients from participating in programs that would benefit them that I can provide as a CPP. And that's Christina Holt.
Christina, I had not planned on speaking about that, but I would welcome a conversation with you to hear more. I do know that the one thing I do know is the state health plan is getting ready to make, my understanding, make major changes in their like the premium part that but I think you're referring maybe to the retirees that have Humana Part D. So I don't know. I don't have a good answer, and and I really don't know enough about the exact problem that you're seeing. So I would welcome a conversation about it so that I can become more informed, and then I'm happy to bring it forward into a conversation with him.
Yeah, and I have to apologize. I think that's Kristen Holt. I just reread it.
Kristen Holt.
Kristen Holt. And then there was another question about, they said there are a number of NP/PA owned family practice clinics, some with NP/PA dispensing, which requires a limited service permit from the Board of Pharmacy. A pharmacy manager is required for these limited service permit locations, mainly to conduct retrospective DRR. Do you foresee CPAs with these practices as well?
I don't know. I don't know. Jen Buxton, are you on? Do you know? Thought I saw you earlier. Do you know anything about that? Has that come up at all? Are
See
you?
if I can unmute. But Jennifer Buxton did say that they're doing this in their practice and they're happy to chat offline. I just wanted to make sure, give you a chance to add anything if you wanted to.
Mm,
See. All right, so Jennifer,
Hey,
if you
Penny,
want
it's
to.
Jen.
hey, Jen.
Hey, yeah, I'm actually doing some of this. So we actually are partnered with another free and charitable clinic that's in a neighboring county, and we're in the process of establishing some practices around exactly what the question asker described, where it's they only are they're pulling back on their pharmacy services physically they're dispensing pharmacy services physically on their site, but they're going to keep their limited service permit for like urgent care type of medication needs, so that the NPs and the PAs that are working in that space are able to have access to a handful of antibiotics and some pain meds and some things that they might want without the turnaround that would be required from a central fill type of establishment. So
That
the
makes a lot of sense.
pharmacist, yeah, so the pharmacist that's actually staying on their LSP license of record is actually one of my staff pharmacists. And she's actually going to be entering into a CPP type of an agreement with those providers as well. So I don't think there's any reason it couldn't be. That's actually possible under the current legislation as it stands pre-October 1st, but it'll be a whole lot easier and more expansive come October 1st. So definitely an area of opportunity as well.
So the limited permit really doesn't have much to do with this collaborative practice agreement.
Exactly.
It has more to do with the fact that you have meds and you're providing the meds through.
But certainly I see that as an opportunity for entree or an opportunity for expansion. I envision that if you're already the pharmacy manager of an LSP, of a practice where the providers are dispensing meds and you're doing retrospective review anyway, you go to that practice and say, here's what I can layer on in addition to what I'm already doing. Let me see how under collaborative practice we can make that relationship more robust and clinically meaningful. Yeah, absolutely.
Yeah.
And I remember I saw one more question. So this is from Mackie King. They asked, related to public population health comment earlier, is the expectation that referrals will still be necessary for individual patients?
Okay, Mackie. Let me say, so one of the things that we worked on within this piece of legislation was we used lots of examples of where like our health systems wanted to hire CPPs, say, to manage all patients discharged from the hospital with a diagnosis of congestive heart failure, right? So in that case, you're not getting like a direct patient referral for Penny Shelton, Mary Smith, John Doe, but you're basically being able to utilize the data, like the collaborative practice agreement is written in such a way that, you know, patients within your site, so site specific, so maybe that's New Hanover, I'm sorry, Novant. I don't know what your new name is down there in Wilmington, but New Hanover Regional, right, is what I always think of it as. Um, that, let's say down at that hospital, so all the CPPs that are part of that system and the providers that, hospitalists that are part of the hospital, as patients are being, and this wouldn't even really be like a hospitalist referring a patient to you, Mackie, to do population health, whatever the population health services are for this patient that's being discharged for congestive heart failure. But your team now has, under the collaborative agreement, the ability to proactively go in, identify these individuals, and then carry out. And the providers that are part of the health system, they are like, they're signed on, you're signed on, and it's an understanding that you're able to do these things. And that's going to be identifying like all the patients that are discharged with X, and these are the services that you're going to be providing. And, and then I guess as part of your agreement, in the event that it's a patient of a physician or a nurse practitioner somewhere out in the community, say maybe they're an hour away from the hospital, right? And their main provider is somewhere out, next county over or whatever, is your agreement may have some aspect of what, if any, information has to be communicated, to the patient's provider should you identify issues through the service that you are providing, if that makes sense. So again, it's kind of wide open now. It's not like you have to have, that patient doctor. That's that part that we took that was very restrictive, that has now been redlined out of our statutes. I hope that helps.
And the last question was actually the first question, which was, will this be recorded and posted somewhere publicly for our members?
Yes. So it's
Okay.
being recorded. As soon as when we launched the webinar tonight, the recording started. Our staff will clean up the front end where we have a little wait time and everything. And it'll get placed on our website. We may actually, that sometimes for new authorities, we will sometimes take a recording of a CE that we do, and we'll pull it in as a resource for a specific page about, test and treat for flu, or about collaborative practice. We might pull it into a web resource page like that. But bottom line, it will be in our on-demand library. However, keep in mind that if you, we may take it down after, like sometime early part of next year, if we find that there's been a lot of changes to what actually got implemented. We don't want to have, you know, inaccurate information out there still floating around. So we may replace this evening's session with a different session. And my wheels were turning. There were so many questions that were really maybe more of the purview of the Board of Pharmacy to answer. And maybe Jay and I should think about doing a talk together in January. Give a chance for all the rulemaking and everything to kind of get in place, and then top of the year we come out with a session where it's NCAP and the Board of Pharmacy kind of co-presenting, have Cheryl, myself, and Jay on there, and maybe that would be of value for our members. But yes, long-winded answer for yes, it's being recorded, and we will make it available in our on-demand library.
Excellent. Well, thank you everyone for sticking around for the Q&A section. And Penny, anything you want to say to leave us off with?
You guys are awesome. I appreciate you tuning in, hanging in there with me. I know it's been a little bit longer, but I appreciate all the great questions. I will say, I'm looking at CD Holt here. Let me catch that. sorry, it's like what's that cartoon about squirrel? Pulled off in a different direction here. But let me just say, I really appreciate it. On Wednesday morning, I presented to another group of pharmacists in the state, and I ended with a slide of there's still so many unknowns, right? We're still working through a lot of this, but I think what is so super exciting about all this is the potential that is going to come from it, and just like pharmacists finally having the shackles removed to be able to give you the ability to do what you do best, which is take care of patients, and to use your innovation and your imagination to sort of come up with ways that are going to fulfill the needs in your practice and in your community. I think that is what is most exciting. So although I don't have answers to everything tonight, and we don't have like concrete, like this is exactly going to be the language, I think giving you a sneak peek and giving you the opportunity to kind of get your thoughts flowing about how you can get started on some of the preparatory work is what really I wanted this evening to be about. So really thank you all for tuning in, and for those of you that contributed to the chat and allowed your mic to be unmuted so you could help answer some questions. Thank you so much. Ty, is that all? Did we catch everything?
I believe our net caught every fish. So this is
Wonderful. Well, everyone, have a good evening, and